Good morning. A lot of excitement today. Welcome to the Department of Medicine Ground Rounds. Today we have a special guest, and I'll soon introduce Dr. Kruger, who's going to introduce our guest. But a couple of things before that. First of all, on this day back in 1851 was the birth of Walter Reed. And all of you know Walter Reed Hospital. Walter Reed was a U.S. Army pathologist and bacteriologist who actually led the experiments that led to the discovery that yellow fever was transmitted through a mosquito bite. 2 years later, on this day, September 13, 1853, was the birth of Hans Christian Joachim Gram. You know who he did, or what he did? A Danish pharmacologist and pathologist who invented the Gram stain. August Crow, I can't say the whole name, another Danish, was died on this day, and back in 1949, Jacques August Steenberg Crow was a Danish physiologist, and he received the Nobel Prize in 1920 for physiology of medicine because he discovered that muscles actually regulated capillaries. And what he did is he killed a whole bunch of frogs. But before killing them, he injected them with India ink so he can follow where the capillary, he can trace the capillaries above muscle. And then he would keep muscles untreated, and other muscles he would stimulate them, and then count capillaries for square millimeters. And he found that at baseline, muscle had about 5 capillaries per square millimeters. I'm just reading, I'm not sure that's true. But it actually went up to over 100 when that muscle was stimulated. And there, his and other work started to stimulate this area of exercise physiology, which I think is quite interesting. Now, I want to, before I introduce Chris, I want to just mention a couple of things, because Barbara Casper sent me an email late last night because she was really excited, and I am too, about how our kids, and I like to call them that way, did at the ACP. And as you know, every year, the American College of Physicians has a meeting, and the winners of the certain vignettes and resident presentations and poster presentations are given an opportunity to go to the national ACP to present their work if they win first, 2, second prizes, and so forth. So let me just tell you the names, because I think essentially all this list is U of L, and I think it's important to mention that. So first place for the student vignette is Nathan Hicks from U of L. Third place was Joel Burnett from U of L. Student research, first place, second place, and third place were all U of L. Jason Parks, Eric Chen, and Jenny Fenn. Congratulations. Resident vignette, first place and third place, U of L. Eric Wilkinson and Ryan Fields. Is it Eric here? Or Ryan? Working very hard in the wards. And then resident research, first, second, and third place were also U of L. Dipali Tukai, Thorsten Luker, and Yitika Bach. So congratulations to you all. Before the applause, Phil Rizos, who you know as part of the internal medicine group and also very involved with student health, won the laureate award of the Kentucky chapter of ACP, which I understand is the highest award that the chapter provides. So U of L continues to do very well. Congratulations to you all. And now I'll have Chris Kruger introduce our speaker.
I can say in Kentucky it's with unbridled enthusiasm that I introduce our newest recruit to our division of gastroenterology, hepatology, and nutrition. Dr. Tom Abell is actually akin to the Abel. He says it's his cousin or grandfather, cousin, and he says all the Abels came from Maryland originally and then settled in Lebanon, Kentucky, and so Dr. Abell is coming home. However, he was born in North Dakota. He has had academic positions at Ohio State, Mayo Clinic, University of Tennessee, University of Arkansas, and most recently we recruited him from Jackson, Mississippi, where he was chief there for about 8 years. His entire tenacious career has been in neurophysiology and understanding why people have nausea and vomiting. And he has been a pioneer for gastric electrical stimulator himself and his surgeons that he works with, placing about 10% of the world's gastric electrical stimulators. I would, without further ado, like him to come up here because he has a whole lot to tell and to teach us about his career and his very important work.
Thank you. It's a pleasure to be here. I hope you can hear me with my, I said yesterday at the KMA, my southern South Dakota accent. I actually from South Dakota, but it's about 400 miles south from Canada. So I'm going to talk today and try to, in about 40 minutes, go through about 40 years. And talking about upper gut motility, focusing a little bit on electrical stimulation. I've got some disclosures. My main funding is NIH. Also, a lot of work with Medtronic, although I'm in the stock there, working with a couple growling companies, advisory panels, and also a lot of work with UpToDate. I grew up in South Dakota, and my dad was from Paducah, Kentucky, but after World War II went up to South Dakota to teach at the university, and so I grew up in a small town, really a village of about 3,000 people, excuse me, with a university, the smallest, the smallest complete university in the country. Between my...
that again, Tom. There you go. Just speak a little louder.
Yeah. Between my primary care background in medical school and my residency, which included internal medicine, OB, and peds, I had about 10 years of primary care practice. Then went back and trained in GI. Actually supported myself as a primary care doctor while I did a research fellowship. Then trained in motility, ran a pancreas transplant program, worked with obesity. Our team planted the first stimulators about 25 years ago. So today, I'm going to give a couple case examples, focusing on upper gut, especially nausea, vomiting, and the gastroparesis syndrome. But try to apply technology to pathophysiology and focus back to primary care. I didn't realize as I list these that Dr. Rowan was going to talk last week about remodeling, but that's actually what I'm going to talk about, because that's really what happens with upper gut stimulation. I'm going to mention the role of diabetes, which is very important, and we learned a lot about the pathophysiology of diabetes from pancreas transplantation, because as you cure diabetes that way, you begin to see the neuropathy progress. The role of migraine, which is vastly underappreciated in upper gut dysfunction. The drug discussion will be very brief because we have few drugs, only we have no really good upper gut drugs available. I'm going to talk about devices. So again, let me know. Got a little bit of a sinus infection, so let me know if you can't hear me, understand me. Just raise your hand or shout. This is a 22-year-old Caucasian engineer from upper Mississippi that I saw. We had upper gut fullness and nausea, really would be called dyspepsia, gradual onset over less than a year. Working as a stressful job as an engineer and then a normal upper endoscopy, no response to PPI. I'll talk about him a little bit later. I'm going to focus on upper gut, which are more common part of GI disorders, extremely common in primary care. And I think one thing I was not taught was to view them as foregut, midgut, and hindgut disorders, at least in internal medicine. But I think it's really a surgical approach, but it's a useful approach because the innervation, the embryology, and pathophysiology is easily separated in those three groups. Conceptually, I keep coming back to the fundamentals that I learned in med school, and we all learned about anatomy, physiology, and then therapy, and if there's no response, to reevaluate. So as a primary care doctor, in a clinic, for example, I used to go to Hayfield, Minnesota, a town of about 400 people, and see 25 people in the morning, and I'd have maybe 3 to 5 minutes with a patient. So I realized we had no idea what we were treating with these patients. So there's a lot of reasons motility can be disordered. diabetes, obesity, other metabolic disorders. But most of the disorders that we've discovered are either inflammatory, autoimmune, or neuropathic, and rarely, quote, functional, which implies not organic. Many are neurologic, and in fact, the enteric nervous system, which was hotly debated about 100 years ago, has now been rediscovered. And actually, a couple of Nobel Prizes were awarded to Hall and Golgi in 1908 on basically this enteric nervous system. The role of migraine is very important. It's the most common mitochondrial disorder. It's about 25% of the population, about 18% of women and 7% of men. But there are many other metabolic genetic disorders that we see, and there are more enteric nerves in the body than in the central nervous system. So what treatments do we have? We have behavioral treatments, which is what my original training at Ohio State was in behavioral medicine. I foolishly thought we could cure ulcer disease with behavioral treatments, which was a total failure. That was before the rediscovery of H. pylori. Metoclopramide, the only approved drug for upper gut dysfunction, is not very safe, and there's really no other approved drugs. And there's one device that I'll talk about that's approved. Surgery does have a role in some cases. So what about our patient? We ordered a gastric emptying test on him, and he actually had rapid emptying, sort of a dumping-like phenomenon. And he began to have cycles of nausea, vomiting, and pain, actually, had several hospitalizations, interfered with his quality of life. And we began him on domperidone, which is Reglan without side effects, without many side effects. After 3 months, he'd had resolution of symptoms, and last follow-up had good response. What do we do if all else fails? And I'm speaking now more from outpatient to inpatient, drug refractory vomiting, nausea, and pain, especially poor quality of life. Referring to subspecialists is important, and we have some investigational medicines, none approved. We consider device and surgery. I'd like to talk a little bit, it was an interlude with that introduction, an interlude about electrical stimulation, which I've worked on for 25 years, and give a case about that, a little bit of a history, and then go back to some new techniques which I think will have an impact on primary care. Not that these are not don't have an impact on primary care, but a more direct impact. I presented this yesterday at the KMA GI Society meeting. 58-year-old white male from UAB, steel plant foreman. For those of you familiar with Birmingham, with the steel mills, this guy was not a wimp. Very, very tough, strong guy. Worked in the steel plant for years. Had chronic nausea and vomiting. Had a failed misfunction. Had a G and J tube. Was on TPN. Extremely poor quality of life. Frequent admissions. Referred actually by his insurance company because he had reached their cap of $250,000 a year, where they decided it was worth looking into other things. And we saw him. The option was continue his TPN, put a permanent J tube or stimulation, and I'll talk more about that in a minute. Excuse me. But patients with gastroenteric symptoms are well recognized and have much suffering, and actually this was totally patient-driven. At the NIH put this consortium together. There's now a version of this consortium, part of the consortium here at U of L. Part of the reason for this is because we've got limited therapeutic therapies available, and GES is one option. So just briefly, to talk about why to consider stimulation. This was about 20 years of my life looking at a series of people with nausea, vomiting, and basically most of these people have neuropathies of the upper gut. Very few have myopathies. Of 101 that had a full evaluation, only one was normal. So contrary to the common view that these people are not organically ill, this was one of our first clues that they are. This was a patient from my mother's hometown in Martin, Tennessee, that with lifelong symptoms responded initially to prokinetics, and then it didn't. And she finally got a J tube, and this is a full thickness biopsy with mucosa serosa. And this is not an artifact. That's the relatively early but classic changes of scleroderma in somebody that had no manifestations of scleroderma, although she did have the SCLA antibody. So we found a lot of surprises. Most commonly were the nerves that we saw, this is a silver stain on the myenteric plexus. We now can stain this much easier with the c-kit looking at Gall cells, which is the same stain they use, CD117, for just tumors. So the diagnosis of nausea, vomiting for chronic disorders can frequently be associated with delayed emptying of gastroparesis, but there are many other causes, and much of my last 40 years since I was in college actually have been devoted to this, and I was assured as an undergraduate in New Haven, Connecticut, that these were all psychosomatic, so I took a year off and went actually to South America. Ended up in the Amazon working with anthropologists, trying to figure out how the mind could do this. Of course, the hypothesis was faulty. These are organic disorders, not psychosomatic disorders, but people have variable gastric emptying. So what are the treatment options once the diagnosis of a gut neuropathy like the severe patient I mentioned? Well, behavioral therapies, which I spent almost 10 years doing, can be somewhat helpful but don't work very well. Modified diets can help. Some drugs are available, as I mentioned, but not many. It's tempting to think that devices or surgery might help. So let's see what the data shows. And I'd like to focus on one technology of stimulation, which is, as we'll talk about later, actually probably remodels the stomach. But it may be a better way to understand pathophysiology and understand new therapies. Obviously, to understand is to be able to then try to look for ways to cure. And for example, with heart failure, understanding severe heart failure has obviously led to new treatments for less ill patients. Electrical therapies I talked about in great detail yesterday, but actually the first published article on electrical stimulation of the gut was 1912 in JAMA. So it goes back using basically car batteries to stimulate the colon. But not much clinical work occurred until the 1980s. Before discussing, I want to mention the author of what I think is the best article on clinical research I've ever read. It's Michael Rollins, who's the head of NICE. Those of you who spend time in UK, NICE is National Institute of Child Health and Clinical Excellence, that basically determines everything that's paid for in the UK. And he wrote an editorial in the Lancet, December 08, January 09, where he talked about evidence-based medicine, observation, and mathematical formulas, and pointed out, though, that even though he's the head of the evidence-based medicine world in the UK, that most things that have been discovered have been observational. The mathematical modeling is probably yet to come in medicine. And he was actually very approachable. I emailed him I was on call, told him I thought it was the best article I ever wrote, and within a half hour, he'd email me back and send me all his slides from his Sardarian lecture. So at that point, I looked and I realized it was Sir Michael Rollins, but I may not have emailed him otherwise. But as he pointed out in his article, all have advantages. So what do the studies show on electrical stimulation? This technology that I've worked on for 30 years. This is a meta-analysis. This is the Cochrane database, speaking of UK, and I showed this yesterday in more detail. But basically, this therapy can be looked at with good being on the right, not so good on the left, and everything. And we went through this in more detail yesterday. Nausea, vomiting, nutritional support, gastric emptying. There's one that approaches zero there, but quality of life improvements are all dramatically improved. Despite that, there's been great skepticism, and skepticism is healthy for new therapies, but it's a much fuller discussion of why there's skepticism of this particular therapy. And for outcome of permanent stimulation, however, as with all therapies, we need to look at symptoms, we look at physiology like gastric emptying, quality of life, survival, and safety. And this is just a couple of slides from what I showed yesterday. Vomiting scores improve over time, symptom scores, health-related quality of life, which relates to costs, and gastric emptying improves. This is the manifestation of gastric remodeling. But could this technology be changed? And in other words, could it be adapted to an endoscopic approach, less invasive, less costly, out versus inpatient. In other words, instead of waiting months and after an expensive therapy, could you tell in a few days? And so that's been our challenge the last decade. And so we about 10 years ago took off the shelf things. Most of what we do is from cardiology. Standard endoscope, endoclips. Actually, we now use Wilson Cook as resolution for those of you that are GI trained. We use transvenous cardiac pacing leads and an external device. And I won't show the video I showed yesterday, but basically you can put this down in about 2 minutes and screw it in the stomach. It's the old righty-tighty, lefty-loosey. It screws right in and it clips. And that looks like it should get satellite reception, but it just actually holds the clips in place, then convert it through the nose to an external device. And you get dramatic improvements. This is, you saw earlier, long-term follow-up. This is the kind of improvements you get in a mean of about 4 days. So you get rapid remodeling. We still had a fair amount of skepticism that this could actually work. So we did a evidence-based medicine study that with 2 randomized sessions, and I won't go into it in detail like we did yesterday, but here's the consort diagram from last year's publication: on, off versus off, on. Most patients were able to be analyzed. What we realized was that people have a rapid differentiation between off versus on in about 3 to 4 days. There's an initial response that could be used, a placebo response at about 24%, which is standard for placebos. Actually low for most placebos. But interestingly, it did not, oops, I'll back up a second. I'll back up. It did not go back to normal. We realized that probably crossovers are not good for things that remodel quickly. And that's one important thing we learned from this. Actually, also nausea. Nausea was different, although interestingly, the 2 groups were slightly different. We did a later post-hoc analysis and realized that the group that was on first was more physiologically normal than the off group, even though they were randomized. So in future studies, people should be randomized physiologically as well. And total symptom scores also separated nicely. So that was actually it's now on clinicaltrials.gov. So our current team for stimulation for those patients that need it is a very detailed process with a complex procedure for screening, surgery, follow-up, because insurers and others, not to mention the patients, are not going to keep coming and sending patients without important outcome data, quality of life, costs, and survival. So what about the autonomic nervous system? If one looks back at the Nobel Awards, actually, I discovered this in doing a talk on history of medicine. The Nobel Prize in Physiology was to, first one in 1906 was to Pavlov, and then Golgi and Cajal in 1908. But you can go back to nobelprize.org, and the award speeches are all there. When I read them, I was taken aback because they're basically the same things we're talking about today. Great debates about nervous function and the role of the autonomic nervous system. People like Walter Cannon, and some of you may know Walter Cannon is a medical student. In 1890, as a first-year medical student at Harvard, he and some colleagues heard about Röntgen, got an X-ray machine in an alley in Boston, got a goose, literally, fed it what is now barium paste, and published it in American Journal of Physiology, because the common wisdom at the time in 1890 at Harvard was that the esophagus had no motor function. It was just a conduit for just pour something down and went down. And Cannon later became head of physiology at Harvard and trained many people, including Dr. Guyton, who I knew at Mississippi. But anyway, the autonomic nervous system has long, and Cannon felt the autonomic nervous system was the key to everything in the gut. The other story about Cannon was, since no one's a public person's life is private, he actually ended up dying of the burns he got from radiation, stroking a cat, because most of his work was done. I don't know if you've seen the equipment in Boston, but it was very, very crude. He had this cat in his lap. He fed it barium out of a milk bottle. and he stroked it and watched what happened. It went down. That's where all the understanding of physiology came from. He got these incredible burns on his hands and thighs from radiation, which is what killed him. But anyway, so there was a lot of work, and Cannon felt that autonomics were the key. So we've, in my pancreas transplant world, began looking at autonomics, particularly before and after kidney versus kidney pancreas, and realized that it's included a lot of things, including patients with migraine. And we have a paper in press on encephalgia on gastric stasis and migraine, which is actually very, very common and underappreciated. This is how we do autonomic testing in a traditional way, at least in our autonomic lab. EKG electrodes under here. This is EGG electrodes, photoplasmography, skin temperature, tilt table, standard adaptation of traditional cardiovascular maneuvers. This is reflex relaxation. This is if you put your hand in ice water and you measure your pulse amplitude in the other, and this is just the pulse part of pulse oximetry. Again, as an old technology, photoplasmography was discovered about 1935, but really was not appreciated that it was a good sympathetic measure. Here's somebody with diabetes, actually a patient of mine, awaiting pancreas transplant, and when they put their hand in ice water, they vasodilate. So that's every blood vessel in the body is not working well. Likewise, put your hand above your head. You don't. That's why you don't faint. Put your hand down low. That's why your metabolic rate is lower when you're resting, and it's kind of in the middle when your hand is right here. And that's actually a physiological marker for migraine. If you ask most people with migraine if they get dizzy when they stand up, they do. So we've been interested in autonomic and enteric nervous system, and in our lab in Memphis, where we were looking at diabetes primarily and somewhat at migraine and Parkinson's, we began to wonder if obesity might not be autonomically related too. There was an old New England Journal article showing a sympathetic abnormality in obesity. And we began a study actually in 1988 with 39 patients, a study that's ongoing. It's probably maybe the longest follow-up with obesity surgery in the world. It's almost 25 years now, where we did baseline autonomics, and then they got surgery, and then we followed them. And our idea was that autonomics may be evolutionarily preserved. So I'm going to show you some data now from our work with Pennington, another story that Doc Pennington was an oil man who left LSU $125 million about 30 years ago to study nutrition, and they still have that endowment apparently, and it's a separate campus of LSU at the dentistry, in Baton Rouge, on the other side of the state of Shreveport, and it has an exercise place, and they don't really have patients, they have participants, but they clinically follow patients. So we've been part of a study called the Baria study, which is it's low-calorie diet, lap band, sleep, and Roux-en-Y gastric bypass. And it's not finished yet, but we've been following them physiologically. So low-calorie diet is a standard diet, 800 calories. Pennington's is very sophisticated. If you sit down to eat the meal there, the table is a scale, so it knows exactly how much you eat when you get up, and they do measure how much the plate goes down in weight. And then the remainder of the study is a maintenance diet. The bariatric operations compared to our sleeve band and bypass. And here's just a picture of those, which are very familiar to many of you. Band, sleeve, and bypass. Apparently, band is fairly common in Louisville. Sleeve is more common right now in Louisiana. Bypass less common here. Interestingly, for those of you that follow politics, Bobby Jindal looked at the cost of obesity in Louisiana, which last year was #1. Now it's back #2 since Mississippi went back in #1 seat again for obesity. But Bobby Jindal looked at the cost and realized that it was probably going to bankrupt their healthcare fund for employees. So offered a program by lottery for obesity therapy for state employees, which had great It's called the Office of Group Benefits, great response. And so right now, actually, if you're a Louisiana State employee, you can apply to get in one of these programs at no charge. And the thought is that down the road, healthcare costs will be less. So this is a predecessor of that. And I'll show you some data. This was last year where we had week 7 of the looked at various weights, BMIs, and average weight loss about 12 kilograms. And using our physiologic study that I showed you we used in pancreas transplant, we studied all the patients, and at least those with the sleeves, which were the common one in Louisiana. This is percent weight loss here, predicted. This the actual. This is predicted. So y-axis is actual, x-axis is predicted, and actually the correlation is very, very good, which so far supports the hypothesis that autonomics may be an evolutionarily preserved part. And the obvious application for this would be, if it turns out to be true, is that you could predict, perhaps non-invasively, what patient should get what therapy. So we'll see, probably another 3 to 5 years before we know the answer to that. So I'd like to show a couple more. Let me take a drink of water here. A couple more new techniques that I think may have application. This is going to go from sort of high touch to high tech. But multiple electrodes in the stomach can show dramatic changes. And actually, those of you that have access to gastroenterology online can look at the journal this month. And unfortunately, this requires an operation. But if you take a 2x3 thing with 256 electrodes. It's a little sort of catheter made flat, developed again from cardiology, developed from cardiac mapping and later uterine mapping, and apply that to the stomach. You get electrograms. This is arbitrarily red is where it begins and blue is where it ends. And this requires a fair amount of computing power, but what one sees in the 24 patients in the world that had this done are patients of mine that were in Mississippi, but you get a normal activation map on the normal controls. You get conduction, you get conduction abnormalities, you get conduction blocks, just like cardiology, and you get ectopic pacemakers, just like cardiology. So this makes sense, but when you consider that this was viewed as a functional disorder, psychosomatic, it's a radical departure, and it caused so much stir that actually last week in Italy, where I wasn't there, there was a forum to debate whether this is really true or not at the neurogastro meeting. But I'll show you a couple of videos here that works. Okay, this is a normal stomach, kind of in the middle part of it there. You get electrical activity that's transmitted distally. And then here's a diabetic patient with some relatively normal activity. In this case, that's blue, but then there's this ectopic activity that starts red and goes aborally. Actually, of our first 12 patients in the article, 11 of them had dramatic abnormalities like this. On full thickness biopsies, which we do routinely, the average number of Gall cells and neural cells was about half of what you ordinarily see. So that's probably what's going on with people, and presumably what's going on with people with nausea, vomiting. Also, since I have a couple minutes, I can show you what happens after electrical stimulation, and then I'll show you a couple new techniques and then focus back to primary care. But we looked at serosal recordings when we put these devices in at the time of placement, and we followed patients for a mean of about 4 years. This was in press this week, actually, in the Journal of GI Surgery. But this is just one patient who had channelopathy. We realized a lot of these people have sodium potassium channelopathies and very disordered electrical rhythm. And after about a year of stimulation, needed their battery changed, and there was really a normalization of electrical rhythm. So probably the remodeling that we saw that begins actually in about 12 hours, this is the end effect of that after about a year. And again, actually, Dr. Roman mentioned Walter Reed earlier. As some of you know, when yellow fever was being, which decimated not only lots of the world, but places like Memphis. Memphis lost its charter over yellow fever in 1880. My mother grew up playing in the yellow fever cemetery across from her house. It was a major problem. But when yellow fever was out, the idea of a mosquito was actually way down the list. It was belonged to a Cuban, as they called him, the crazy Cuban. It was only after the other ideas were died, basically physicians died trying to prove their theories. They said, okay, we'll try this crazy mosquito idea, which was true. So right now, these views about electrical activity remodeling are still in the minority, and wouldn't equate myself with the discovery of yellow fever, but I think you're seeing an evolution of understanding of disorders. So one other realm into new technology, then I'll get ready to close. But biopsies that we do routinely in endoscopy, we look for standard stains. I showed earlier have some full thickness biopsies. We do a lot of other things. I'll back up here. In the OR, we apply various energy thresholds. Again, it's like cardiology. We give energy thresholds before the device is turned on. If people fail stimulation, if they fail temporary stimulation, they get a very thorough neuromuscular evaluation, including often genetic studies by skin biopsy. And in some cases, patients end up on immunotherapy, some end up on IVIG, steroids, or CellCept. What I'd like to show next is some work from my colleagues at the University of Minnesota. And this is a gastric antrum biopsy with a normal staining for nerve cells. In other words, a regular biopsy, you put it in what's called a Zamboni fixative, or could be one of the other special fixatives. Use a confocal microscope, and you can get these kind of stains. And this is from Bill Kennedy's lab in Minnesota. Here's work that he published last year in neurology. A normal stomach and a diabetic stomach. So we actually now just finished a pilot with him looking at full thickness biopsy versus this. And it's possible in the future that one could just do an endoscopic biopsy and determine whether there's neuropathy or not. So the future of stimulation, and then I'll come back. We use these integer algorithms. We use it for severe refractory cyclic vomiting, because cyclic vomiting and gastroparesis can overlap. It's been used in pediatrics, which is part of my background. It's about 5 to 10% of my patients traditionally are pediatric. It's been used in cancer chemotherapy. We've used it, and MD Anderson is now about to start a trial. We've developed a wireless model that doesn't involve a wire, but it's still in the animals. And hopefully we can learn more about pathophysiology and remodeling. So again, over the last few decades, these complex patients, tertiary to quaternary patients, require teams, hopefully can be able to spend some of that data back and share it. I think the internet's been great, as most of my patients, even 15 years ago, had the internet. Presumably if they were sick at home, they didn't have a lot else to do but get online. But it's, I think, very helpful. The emphasis now is on outcomes, and my own goal is to try to learn what we can and apply it to primary care. So again, disorders of GI motility are common, especially the upper gut. I focused today on gastroparetic symptoms, and I focused a lot on stimulation because that's what I've worked on. But I use it just as an analogy of how technology can help us hopefully understand pathophysiology better. Diabetes and migraine are two common disorders that have gut manifestations. And one thing with migraine is we have a study on now still in Mississippi, which is based on the idea that migraine actually may manifest first in the gut before manifesting anywhere else. The behavioral treatments are suboptimal. There are some response to medications, but unfortunately we don't have very many Drug refractory patients are not uncommon, may not be common, but they're not uncommon. And in hospital services, you see these patients a lot. Some may respond to electrical stimulation, and hopefully other new therapies may be forthcoming. There are going to be new guidelines for gastroparesis, which I'm on a committee for those, and you never know what they're going to be like till they actually come out. I've realized the guidelines, which are evidence-based, are also very political guidelines, but they were designed to be used by primary care physicians, and I think will be quite helpful. Should be out in January, February 2013. So to summarize, I think we have a better understanding of upper gut disorders than we certainly did 40 years ago when I was an undergraduate. I think new technology offers new understandings. Mechanisms can be studied by autonomic enteric physiology and particularly enteric morphology, which I didn't talk about, but full thickness biopsies, including electron microscopy. All of these patients, the severe ones that are biopsied, have marked changes. Mechanisms, like I mentioned over and over again, offer options for new therapies and maybe common diabetes and migraine. And hopefully we'll have some new applications of technology for stimulation. We'll be happy to see any drug refractory patients here. You can reach me at email, any physician, call. I'll give you my cell phone. You can text me. I don't always answer it during the night, but I'll answer you quickly. And appreciate the chance to talk today. Thank you.
Thank you, Tom. One thing I would recommend is that never say that you borrow a technique from cardiology. But anyway, thank you so much. I was going to ask you, you talked about diabetes and you talked about migraine. You showed me beautiful pictures of the neural network in the stomach of a diabetic patient versus a normal patient. Help me understand better the migraine relationship. How does that work?
Well, I think it's not fully understood. We have this article will be out in Hepatology soon, but we've known for a long time that although about 25% of the world has migraine, 50% of our patients have migraine. And it's also known that, and I don't know how many people here are aware of this, but with recurrent attacks of migraine, you get brainstem deposition of iron. So you actually get morphologic changes in the central nervous system. Now it looks like with recurrent migraine, you probably get changes in the enteric nervous system as well. Now it becomes a question of chicken, egg, or omelet, what came first. Sure. But that's the other reason this is being driven is there are now a number of new migraine drugs that are going to come out that are parenteral, that are inhaled. It's not approved yet, but it's supposed to be approved in the next year, that are inhaled drugs. So the nausea and vomiting is not as much of an issue, and it looks like those drugs improve GI symptoms as well.
Interesting. Questions? Ted.
So H. pylori has gone in and out as a clinical cause for dyspepsia. Of course, we know that H. pylori is associated with chronic inflammation. Has anybody looked at the impact of inflammation on the enteric nervous system in the stomach? Because, say, chronic inflammation in the colon from inflammatory bowel disease can definitely cause
So the question is for HP or inflammation?
For HP-related inflammation, any impact on the rhythm, production, and the nervous system?
Not much, actually. Ironically, the only area that I know of is there's been talk about that. This may seem far out, but I was talking to one of the Parkinson experts yesterday, and there's recurrent thoughts that H. pylori has some effect on Parkinson's in the gut, which is very, very interesting, because Parkinson's also may originate in the gut as well, but there's been very little work on that. A lot of work on inflammation in general. And again, things like diverticular disease, now, as you would be aware, looks like it's an inflammatory disorder, chronic diverticular disease, which is new, even though it's an old illness. So a lot of it boils down to the same kind of inflammatory mechanisms. Very similar to the liver pictures, very similar to the lung pictures from last week.
So the majority of the people have a gastric neuropathy, including diabetes. Do they have a use of peripheral nerve conduction testing? Will you be able to uncover the same findings that you might be informative as to what you might find.
Would you repeat the test for the VA group?
Yeah, the question is, people with diabetes, for example, when they have gut neuropathy, do they have peripheral neuropathy? It's variable. Diabetes, is, as you know, is notoriously spotty where it is its effect. So I think the only study I know about that was one in gut a few years ago, and they said basically you can't predict, you got to test. On the other hand, things like achalasia, there's a German study over 100 years ago, sectioned every cell in the body with people with achalasia, and they had neural abnormalities everywhere in the body. So some of the disorders are very widespread. I think diabetes, it's not clear. The pancreas transplant data looks like most of the neuropathies improve with the new pancreas, but the vascular abnormalities don't. Retinopathy, renal failure doesn't, but everything neuropathic in theory should be able to be improved. So it's that's that whole cascade. That thought is that, so as you know probably better than I do, cyclooxygenase may be part of the pathway for diabetic injury in the gut. So there's now a whole series of pharmacologic interventions with cyclooxygenase trying to block that.
So to take us back to primary care, I don't see a lot of chronic gastroparesis, but we see a lot of people with kind of non-ulcerative dyspepsia. We've all been taught as kind of the upper GI version of irritable bowel syndrome. There's something wrong with their nervous system. We don't exactly know what it is.
Right.
So we try them on a PPI and we put them on a TCA,
Right.
ultimately, and hopefully it works. So is this where we're giving us a better understanding of what we've been calling non-ulcerative dyspepsia? And what about therapeutics for that coming down the road other than just amitriptyline at bedtime?
Yeah, it's good.
Repeat the question, or at least
So the
the
question is
question.
about particularly upper gut disorders that are not frank gastroparesis, that we're treated with PPIs and things like tricyclics. Do we have a better understanding? Well, one thing that will happen is we just next week we'll finish the only double-blind randomized study ever done with tricyclics for upper gut dysfunction. That will be out later this fall. 120 patients, so hopefully we'll get a better understanding of that, because that's never been studied. I actually was one of the first people in the country to use that 30 years ago, but because of side effect reasons, I don't use it much in our severe patients because they can't keep things down. We need better drugs. We had some drugs like Zelnorm that are gone. Domperidone not really here. Great need for other drugs that are not here yet.
You talked about a couple things that seemed predictive, one of which was the autonomic testing to predict who's going to respond to bariatric surgery. And
Right.
then the second piece being, and if you could just comment briefly on that. And then the second was, do you know which comes first, the diabetes or the dysfunction in the stomach? And have they mapped pre-diabetics or hyperinsulinemics to see what is their neurologic mapping look like in the stomach?
The short answer, the question is, what about diabetes, and have we mapped people that are earlier stages? The answer is no, because it's so invasive to do that. But that's one of the advantages of the mucosal biopsies. If we can do that, and also mucosal electrical activity, we could perhaps do that. There's been a little work done on that in Michigan, but not much. As you know, as most things in medicine, we have these very, very severe patients that we know a lot about, and then we try to extrapolate back, which has its own dangers, problems.
So, what you commented that when you do this electrical stimulation chronically, that you get remodeling. Does the remodeling start with the muscle and then go to the nerves, or nerves and go to the muscle? Do you know what the target here is for the electrical stimulation?
It's not known. It's thought to be nerve. There's some work now going on in Boston with, I mentioned yesterday, with stem cells in kids in their gut, of trying to look at stimulation to see if it causes regrowth. One thing I didn't mention is it does stimulate ghrelin. That's well known. So presumably, if ghrelin is stimulated, there is some neural mechanism, but it's unknown.
Final question.
Your first case presentation was a guy with racket implant.
Right.
You chose domperidone to use in that case. Does that underscore the the uselessness or usefulness of a gastric emptying test in that type of a patient, or why did you choose domperidone?
Well, the question is why the domperidone was a patient with probably cyclic vomiting and emptying. First, the emptying was, I think, to demonstrate that he had some disordered emptying. Domperidone, just because it's a safer alternative to than metoclopramide long term, with much less risk of CNS side effects. Unfortunately, it's not as readily available, but this particular patient actually had access to it out of the country, so which is how he got it.
But you said he had rapid emptying, right?
Rapid emptying, yeah. When it's rapid's still disordered. So what happens with disordered function, and actually about 10 to 20% of diabetics are rapid emptiers. With the rapid ones slow and the slow ones speed up. You get normalization. So it's much like dumping syndrome.
Tom, you mentioned about your mother playing in a yellow fever cemetery, about the doctors who had died. It turns out, and I left this morning out because there was too much to say, but there was a young man who died in 1900s on this week actually, who was experimenting in Quemados, Cuba, with mosquitoes that were supposedly infected with yellow fever, and he died 2 weeks after he was infected by the experimental mosquitoes. And one of the further proofs that yellow fever was transmitted by mosquitoes, and it's sort of interesting you mentioned that, because that happened actually this week. Thank you so much. Thank you for joining Abell, and I hope you get a lot of people calling you. Thank you.
So are you established now in Jewish, or what's going on there?